When we first started the fellowship, it was for MDs only. But you can see over the years we realized, because health and healthcare is about everybody, and doctors are not the only one who deliver care, they're not the only one who understand policy. So I think that diversity is really helpful, because so many of the policies are not only affecting doctors, they're really affecting a lot of other disciplines as well.
I think the colleagues in cohorts among the fellows are selected intentionally. And I have the privilege of having been on the advisory board before and having screened applicants and having helped put together a cohort that we think would be balanced in every way, geographically, in terms of professional interests and so forth.
I'm very grateful that it was not a group of solely nurses, because I think the learning for me was enhanced because I had these different perspectives and different backgrounds.
The great thing about RWJ is that they put a lot of us together, diverse cohort, not just race and ethnicity, but really geographic backgrounds. Also, specialty background. So we have someone that's public health our year in climate. We have a nurse leader. We have a pharmacist. We have a primary care doc. We have an ER doc. So we have a nurse midwife. So lots of, and then the implementation scientists. So we really are representing the spectrum. Everyone
brings their lived experience. I've had a very different lived experience than a lot of my colleagues, and I bring that with me. I really focus then, and I do now, on issues of health equity, health disparities, and that conversation needs to be a part of good policy.
When I applied to Robert Wood Johnson Health Policy Fellowship, I didn't realize that I was probably like the third Native person to go through the fellowship. So a lot of folks actually learn from me, but I'm learning also to navigate these systems in which we're engaging in. And so it's not necessarily that I have only a tribal policy lens, but more of like a broader health policy lens and how they are integrated and they're like bridged.
I am a clinician who came from a county in central Appalachia of 35,000 people. I spent my entire clinical practice working in an area that was high in levels of poverty, low in educational attainment, and came to this fellowship as almost as an outlier. There aren't many rural fellows, so I believe that I brought a perspective to this fellowship and was able to gain tremendously from this fellowship, topics and knowledge and talking points that would be mutually beneficial for rural populations.
I was a professor at Berkeley. My appointment, however, was in the business school, and I'm trained as a lawyer. And I had a special expertise in the developing medical technology. So I did apply, and the challenge was being such an untraditional candidate, how to persuade people that my expertise was also very relevant, even though the path there was not traditional.
I think they did a good job of getting folks from really different lenses: emergency care, hospital settings, mental health, nursing. I was in sort of the community-based organization space as well as social work and law.
We had, for example, a psychologist, and then we had a trauma surgeon who'd done very deep, very hard medicine, and we had a nurse practitioner who'd been for 2 routes of military duty in Afghanistan.
We also had a mix of folks that were more Republican-leaning versus more Democratic-leaning, and even with that spread, I would say there was probably a spectrum in terms of political beliefs.
Well, one of the most startling diversities were we were sort of half Republican and half Democrat, and you almost never see that. The hardest thing was being 7 to 10 years older than my co-fellows. I almost didn't apply. I thought maybe I'm too old. And I remember thinking, I am going to train until I have the physical fitness level of the average 30-year-old. I remember showing myself that you can do this. I was physically fit enough that nobody thought of me as the little old lady fellow.